Thanks very much. So that's a good question, and I might take the question in almost the reverse order. So I think it's important to think about some of the immunological barriers to a good immune response, and then talk about how we might actually be able to work against that. So one of the biggest challenges about treating lymphoma patients with immunotherapy is that there are many immunological barriers to a successful and an effective anti-tumor immune response. So just reminding folks, you basically need a T cell that can recognize a tumor cell, become activated, stay activated, and persistently go after the tumor until it's eradicated the tumor. And then preferably have immunological memory that will allow it to come back at a later time should the cancer reoccur and go after it one more time. That's all quite challenging because of a number of factors. So the first thing that often happens is the way in which the immune system can actually see the tumor is compromised because MHC molecules, which are the way in which antigens are presented, actually are downregulated or lost. So again, it's like the tumor cells are somewhat invisible to the immune system. Secondly, what can happen is you might see the tumor as a T cell, but when you become activated, there's an immediate negative signal that shuts you down. And that's often through molecules like PD-1 signaling or CTLA-4 signaling. And so because of that, the cell, instead of remaining active, becomes deactivated. A third problem is the environment in which the T cells are trying to be effective is very suppressive. Other cells like regulatory cells or myeloid-derived suppressor cells or other macrophages all dampen things down. And then finally, sometimes because of the persistent stimulation of the presence of the tumor, the problem is that in time, the immune system gets worn out from doing good and becomes exhausted and is no longer effective. So you might say, well, how do you fix all of that? Well, there are a number of immunological strategies that are being used right now to do that. So the first is, because your T cell may struggle to see the tumor, if you engineer your T cell so that it sticks onto the lymphoma cell, it will actually then become activated and be seeing the right thing right away. So CAR T cells do that by putting a chimeric receptor into the CAR T cell. And secondly, bispecific antibodies will stick to the tumor cell and stick to the T cells and bring them right up close. And when they do that, again, the cell becomes activated and knows exactly where to go. The second strategy is to stop the cells becoming switched off once they've actually seen the tumor. And that's often through these immune suppressive ligands like PD-L1. And blocking PD-1 signaling has proven, for example, in Hodgkin lymphoma to be very successful, not as much in other lymphomas, but other immune checkpoints like that, and those include things like LAG3 and TIM3 and TIGIT, are all now being tested, and to see whether if you block those signals, you can actually get a good response. A third problem is all of these other cells that are present that are actually troublesome in that they actually suppress the immune system. So one of the ways to improve that is either to target them and take them out. So for example, a molecule like CAM-ET, which is a CD25-directed antibody drug conjugate being used in Hodgkin lymphoma, is very specific for Treg cells and actually may take them out. And mogamulizumab in T-cell lymphoma goes after Treg cells, and that may be very effective. And the other way is to take monocytes and macrophages, which are often suppressive and unhelpful, and turn them into part of the immune system targeting the tumor. And that's now going through some of these approaches, such as CD47 blockade to promote the eat me signal and prevent the don't eat me signal. So as you can hear, multiple immune barriers, but equally multiple immune approaches that are actually specifically targeting that.